So we're going to talk now, we're going to switch gears a little bit and talk about where I spend most of my time. The castration thing was a bit of diversion, but we spent a lot of time thinking about how do we deal with respiratory diseases. And my colleague and I at the university, Dr. Aldridge, and then my buddies in the feedlot business, Tom and Tom Knopfler and Wade Taylor, we said, you know, we really struggle providing adequate treatment if we don't get the case definition right. So if we don't adequately define the case, it's bloody hard to assess, are you making progress or not? So we've spent the last 5 or 6 years thinking pretty hard about what tools can we use to do case definition. And I will give you, I'm going to blow the punchline, the fever stick ain't it. That's also called a thermometer. That ain't it. So how do we have better tools? How do we put other things together to allow us to accurately define where that calf is at when he shows up in the treatment chute, so we can provide the appropriate therapy for that critter to improve his probability of success during the feeding period? So I alluded to this in the last presentation, but most of the cattle get sick early. 45% are going to show up in the first 24 days on feed. If you look at the first 50 days, it's about 75%. Any of you who work with feeding cattle, this is not news. This is where we're at. That's about a year's worth of data, a little over a year's worth of data, and about 275,000 treatment records. So a fair amount of data to tell us where we're at. So this is really our problem. And Dr. Constable was downstairs talking about how we educate students and how we ought to think about specialization, and commended the European group on that we have beef specialists who happen to think about other things, i.e. parts of the body, compared to the U.S. model where we have ologists who like to think about the eyeball across all species, but maybe not the whole critter. And this is really one of my favorite quotes to say, I don't just want to treat the disease, I got to treat the whole patient who has the disease. And that's the individual calf in this case, it's the feed yard in this case, it's the people taking care of the critters in this case, that are all really important to say, how do we improve treatment outcomes? How do we improve judicious use of antibiotics? How do we provide a more welfare-friendly environment for these cattle before we harvest them for food? So when we think about case definition, right, we normally think about at the top here bugs, because we really like to talk about pathogens. And I've decided over the last 4 years I don't know what a pathogen is, because manhemia exists in all these cattle. Sometimes it causes disease and sometimes it doesn't. So I'm not sure I want to think in a very bug-centric world of there's this bug, therefore I do that. Because when I really think about bugs, I'm thinking about pathogens, but this bucket of normal microflora, we're just starting to untap what's happening there. And you'll hear a lot of discussions at this meeting about microbiomes and what's happening in the respiratory tract and what's not happening. This is a new area of science that is still a little bit gee whiz to me. I don't know if we really know what we're doing with it, but new technologies let us get to the bottom of this and figure out where we're at. So we like to think about BRD management, not just in the bugs. We really want to think about what's going on with the immune system. And we tend to think about the immune system as what antibodies are there, or what's the adaptive immune response, but I'm really more interested in the mucosal immune response, or the local immune response, and what's happening signal-wise at the level of the interface between the bugs and the calf where that can get in. So what's going on in the respiratory tract? And then as that response occurs, what's happening with tissue changes and what's happening both systemically, which probably has a lot to do with mortality. Calf's got a lot of extra lung. He doesn't, 40, 50, 60% of his lung being involved with pathology isn't enough to kill him. But when we get systemic involvement, that changes very differently. And then what's going on locally and mucosally with tissue changes, i.e. what consolidation is happening, what tissue damage is happening, to understand where we're at in this progression of disease. Because when I think about what bugs are there, what's the immune system doing, and how are we doing with tissue change, I can now start to be able to describe BRD in a much finer manner to allow us to guide therapy in a way that's much more likely to be successful. So when we think about building case definitions, we think about, I'm going to want a case definition, and we're going to talk about which organ system's involved, and we'll talk about this in a second, how we do this, and severity. Then I want to measure outcomes. This is the reason I started screwing around with cattle, although I really like to work with cattle. I live in Illinois, and we have a lot of pigs. We don't have many feeder cattle anymore. But it's been an opportunity to really look at this measuring outcomes and what happens when we do something. And here's another sidebar. If 70% of the critters you treat don't get better by themselves, you're doing something really wrong, because they do. In spite of us, they get better. Right? I tell students, don't believe your own BS. Don't get too confident in what you're doing, because they tend to get better on their own. And this really gets around measuring outcomes. And then we're going to use that outcome data to modify interventions. And so if I don't have a 3-step process, and I approach this systematically, I'm unlikely to be successful. And what you're seeing is, if you look at the human cancer literature today, they're doing this molecularly. They're doing this with TB today. And so how do we define the case definitions better, more precisely, so we put the right therapy with the right appropriate disease? So how do we build this enhanced case definition? We have kind of a 4-step system that we use to teach this to students. And shockingly, we can teach it to cowboys in feed yards. I actually think cowboys are easier to teach than veterinary students, so I don't know what that says. But so 4 steps. 1, how severe is it? Is it mild, moderate, severe? How long has it been going on? Which organ system's involved, and is it primary or secondary, and where within that organ system? So I can have pneumonia, right, also known as lungitis. It can either be in the airway or the tissue, or it can be in both. And that can be primary or secondary to upper respiratory infection. And then finally, what kind of pathology is going on? Is it a physical change or a functional change? If I describe those steps, so a mild acute bronchopneumonia has a very different outcome than a severe chronic bronchointerstitial pneumonia with advanced consolidation. Does that make sense? That makes me think very differently about what kind of case am I working on, and what kind of intervention should I apply, and what kind of a prognosis should I expect? Because I'm going to tell you, if you're treating all severe chronic pneumonias, you don't have a pneumonia problem, you got a cow farmer problem. They don't know how to find sick cattle. That really changes your intervention strategy, right? Because my intervention strategy now goes from which antibiotic do I use to how do I train the people to do a better job, or better yet, work on people's motivation to do a better job to find sick cattle. So this helps us be holistic about treating the entire feed yard to move the ball forward. So we've done a little bit of this. I told you I'd blow the punchline earlier. We looked at, so when cattle are pulled, we looked at what's the correlation between the thermometer, temperature over 104.5, which is 40, and case fatality rate. So that's those that die if treated. And again, we've got a couple 100,000 records in this data set, so it's a pretty reasonable data set. The correlation is 0.18. Not very good. So I said, well, what if we put a stethoscope and we listen to their lungs? Well, the correlation is basically the same. So you get a little moderate improvement in clinical, right? It's a little better. It's 29% better than this. And if you put them together, it's 50% better. But it's still not very good. And the reason being is, and auscultation's got a huge knock, because they said, well, it's not repeatable. You're right, it's not. When Tom Knopfsinger does it, it's right. When Jim Lowe does it, pretty sketchy. I got bad hearing. So how could we improve that? So some clever guys came up with a way to take a microphone, and that's all this is, record those sounds, and then process those sounds with an algorithm to say which sounds and which pitches, whether we can hear them or not is irrelevant, are related to higher morbidities or higher case fatality rates. So, the stethoscope built by Geissler Corp records 8 seconds of sound, processes that in a piece of software, shoots a number back to the cowboy that says between 1 and 5, 1 being normal, 5 being severe chronic. This is a severity chronicity scale together. They're combined. It's not perfect. It was designed so that in each increase, 1 unit increase in lung score doubled the case fatality rate. That's where it was started at when they started to calibrate this thing looking for sound. So what did we do to figure that out? So we took 17, almost 18,000 cattle from 13 different feed yards. We took their lung score, their body weight, their rectal temperature, and we created a case definition per BRD, precedence, severity, and chronicity for each animal. We said, okay, this is where it's at. And then we measured the case fatality rates, or i.e. the outcomes for all those cattle. Pretty straightforward, pretty simple. Again, it's the power of numbers that become available here. So what did we figure out? For each 1 unit rise in lung score, case fatality increased by about 50%. And for 1 degree increase in Fahrenheit and rectal temperature, and I apologize for the Fahrenheit, this is just how we think in the US, we had about a 19% increase in total born, or in risk. So body weight and cattle that are heavier tend to die at a lower rate than cattle that are light, but it was not statistically significant. So what does it mean? 1, we can use multiple rapid diagnostic tests, really change how we can think about applying therapies. I will give you a sidebar. When we go put this in most of the feed yards, the respiratory case fatality rate drops by about 40% the first 3 weeks it's in the feed yard. I did not know a stethoscope was therapeutic. But what we figured out is that when they weren't using any auscultation and they put the fever stick in the cow's rectum and it said 105, they said, BRD, we'll give it our antibiotic of choice. Pick it. It don't matter. They would stick that in that calf's neck. You know what we discovered? That antibiotics, Draxin, isn't worth a crap for toe abscesses. It isn't worth a crap either for bloats. Nor is it worth a crap on a hot day when they're just 105. By merely getting the case definition right, our respiratory fatality rates dropped because at least we were treating the respiratory calves as respiratory calves. And so there's real power in using advanced diagnostics, chute side, calf side diagnostics to improve this process. We're under real pressure in the U.S. to reduce antibiotic use. We believe we're going to have to figure out how we justify. We will not give up the fight that sick animals need antibiotics just like sick kids. But we probably need to quit giving antibiotics to healthy animals. And so we've got to be able to come up with ways to do a better job of identifying which cattle are sick and are truly sick and therapeutically and really need these therapeutics if we're going to be successful. So thank you.